Hey everybody, it's Dr. Radley Griffin and Dr. Mihaela Telecan from Florida with our weekly low-carb chats, and we wanted to apologize for last week. We had some wind difficulty and all of our terrific information wasn't as clear as we would have liked. So out of request, we want to talk about our low-carb labs again, and hopefully we do a good job on this chat like I think we did last week and get the information across, because this is too important for us to skip over. And so we're having a redo, so hopefully that's okay with everybody. But hi, how are you, Mihaela? How are you doing today?
Hello. Good. Not windy today.
I know, you're in a very nice room.
I'm back in my new office, but the picture is not hanged yet. Can
now
you see?
Look as if you're standing. So
my bridge is here. Oh. I'm standing. I have a stand-up desk.
Oh, nice.
And sometimes I stand, sometimes I sit. So today I chose to stand.
Well, good. Well, very good. It's in the spirit of the chat here, right? So that's really good. So today we're talking about low carb labs. As I love being a physician, you know, we love labs. We love looking at things, and we especially love labs that we're able to influence. And I think patients really like that too. We've seen the Cheerios commercial where the little kid is putting Cheerios in the dad's pocket so they have better looking cholesterol, you know, so it's in people's minds. We all want good looking labs. And that's one of the wonderful things about low carb living, is that it truly can reverse these labs that are troublesome. And I think people need to understand, we want people to know if they're part of the majority of the population that has insulin hypersensitivity or metabolic syndrome, where are they at in this spectrum? It's so important for everyone to know. And we're trying to compile a list here, because not everybody is going to have just completely awful looking labs. There's going to be some subtleties here within lab work. And for instance, when we talk about liver inflammation, sometimes we need to look a little bit more specific than just the traditional liver enzymes. And so we're going to talk about the labs from a metabolic perspective, from an insulin overload perspective, from a fatty liver change, inflammation. We're going to talk about some of our favorite labs. This is not a complete exhaustive list. It's a very concise list. It's very cost effective. There's some really nice tests out there these days. They can be expensive. There's some expensive genetic tests which help us as well. But this, I think, anybody can go to their practitioner, to any lab test now, get these tests ordered, and get some really dynamite data. Anything you want to add to that, Mihaela?
I think this is a great startup point. And I feel like, I don't know who said this, but this is very well said, measured on gas. There are some things that it's good to measure, because for one thing, knowledge is power. Again, if you measure your glycemic control or cardiometabolic markers and they are way off the chart, it may act as an incentive for someone to take action. Right. And then down the road, if the person takes action, when I say takes action, I refer to lifestyle changes, right? Involving diet, sleep, stress management, all that. And then 3 or 6 months later, they retest the same numbers and they see improvement. It also acts as a motivator and reinforcing agent. So the person continues, because at time it can be difficult to follow this therapeutic lifestyle that we are talking about, the high fat, low carb. Right. So yeah, I think there is power in knowing and testing and measuring, and it can be done, like you said, in a simple and cost-effective way.
Right. Yeah, you're right. I think it's, a lot of us too, we think we're doing pretty good. We're feeling pretty good. But if our markers are telling us something different, we don't perceive disease until, unfortunately, it happens sometimes. So it's important for us to follow trends, and it's really important, especially if we can reverse that with a little tweak here and there in our life. So
it's being proactive.
Absolutely. So true prevention, which I think is really lacking. So let's get right to it. So again, what we're trying to prevent here is, treat insulin hypersensitivity syndrome. We're trying to identify it very early in the process. This is also known as metabolic syndrome. And often, Mihaela, as you know, I love looking at the heart arteries with our calcium scoring or our coronary artery angiography. And a lot of times I'll see disease. So if a person has heart disease or coronary artery calcium, this is an immediate trigger for me to look retroactively at where is the metabolic problem occurring in this patient. So it also helps me identify and get more specific on how I can prevent that disease in the future, right? Further disease, rather. So let's get started. So here's our first thing we like to look at, a fasting lipid panel. I think there's some debate whether or not this should be fasting or non-fasting. I do prefer fasting on this still. And the main reason is because I'm looking, and a lipid panel is basically 4 things: cholesterol, HDL, which has been called the good cholesterol or high density lipoprotein. LDL is called bad cholesterol or low density lipoprotein, and triglycerides. And we've been told LDL is the most important marker here. I respectfully disagree. It's not a great marker at all for us. It can fluctuate. It is. There's been reports that we can feel pretty safe about LDLs as high as 300, for instance, because we're finding out that half of the heart attacks, for instance, are in people with normal LDL cholesterol. So it's not a strong predictor. So the ones I really like, and Mihaela, I think you like these too, are triglycerides specifically, fasting triglycerides, and HDL cholesterol. And the reason it's important for us is because it shows us how insulin is interacting in our system, because insulin does something very specific with these chemicals. And we know that in a high insulin state or an insulin resistant state, HDL cholesterol will be low, generally, and triglycerides will be high. And the values we like triglycerides generally less than 100, sometimes even less than that if we can.
Oh, yes. And
then we'd at least like the HDL cholesterol above 40, if we can. And it's so neat to implement a low carbohydrate diet and watch the triglycerides just plummet. And the HDLs, though, they can take time to actually increase in the system. So that's something that can take time to increase there. Mihaela, anything you want to add on our cholesterol panel?
In the beginning, when someone starts the low carb, high fat eating, especially if they lose rapidly a great amount of weight, let's say, 30 pounds in a relatively short period of time, they can, if they happen to test their cholesterol during that time, they may register an increase in total cholesterol and LDL. And that is because some of the cholesterol, the LDL, actually gets stored in the fat cells. And during the weight loss process, it gets shuttled to the liver. So transiently, it will be increased. So I say, do not worry. Either don't test until you kind of reach a plateau in your weight loss, or if you test, try not to panic about it.
Absolutely.
And if you test that, again, look at the ratios, like the total cholesterol and HDL, also with cholesterol and triglycerides, as well as if you are afraid of you have cardiovascular family history, then it may be worth looking at the particle size.
Absolutely.
And the oxidation of, like, is the LDL oxidized? Do you have the very small dense LDL particles? Because these are the ones that are more atherogenic, not the larger LDL. And then also HDL, if you have the ratio between them, it's good, and it's the large one, it's also protective. It's just like you said, it has very little correlation with cardiovascular events. However, because of most people are so fearful about this, to be safe, then sorry, you can go and do additional testing. I wanted to say what I have in my book. So I do the ratios between HDL and total cholesterol, and then it's percentage times 100, and the number, if it's greater than 24, is good.
Okay.
And the other one, I divide total triglycerides by HDL, and if it's less than 2, again, it's an indication that the particle size are not the non-atherogenic ones. You're using the same probably.
Yes, I am. Yeah. And again, I want to be clear here too, for those patients who we've identified heart disease, either with a scan or they've had a prior heart attack. This does not necessarily apply. I do use medications. I am a physician. I will prescribe medications, appropriate medications, cholesterol lowering medications, especially to harness their anti-inflammatory effect while the person is healing themselves. But I am of the opinion, once a person's metabolism heals over the years and they're no longer in this horrendous metabolic state, atherogenic state, I am a believer that we can come off of medications once stability is reached. I'm not of the school of thought that says once on a medication, you're on forever. Right. I do treat with medications. I treat with the most modern medications that exist. Currently, it's the PCSK9 inhibitors, wonderful medications for us. But I with the idea that we're treating a disease, we're preventing a problem, but ultimately our goal is to get off of these therapies because that shows healing at some point. Right.
So while the person changes lifestyle, you also treat the problem.
Absolutely.
And then as the body regains its normal functions, the person may be able to go off medication.
100%. That's always our hope. I agree. Always our hope. Yeah. So the next thing let's look at, so we that's our basic cholesterol panel, great information, focusing in on the HDLs and the triglycerides. And then the next, and these are really in random order. I do like to look at an inflammatory marker because metabolic disease instigates inflammation. They're one and the same. You can't have a metabolic syndrome and not have inflammation. That's what the disease is all about. So this stands for highly sensitive C-reactive protein, meaning it's a very specific marker measuring inflammation within the bloodstream itself. And it's a very interesting test. It lets us know if a person has a low level of inflammation or damage happening within their vessels, and especially over a prolonged period of time. It's this low level inflammation that is sometimes a hint that the body is aggravated by something. And it's up to us to try to identify the source of inflammation. And a lot of times it's related to visceral fat. People that collect a lot of organ fat around their midsection is actually inflammatory, and we're detecting that in the bloodstream. And Mihaela, you made the comment last week that there's a differentiator. There's also a test called a CRP or C-reactive protein, and that's not very specific because you could have a splinter in your finger and the C-reactive protein could be elevated. So we do want the very specific or highly sensitive CRP. Yes,
totally agree. It's a big differentiator. And maybe I didn't mention when we look at triglycerides, because sometimes maybe the cholesterol it's okay still, but the triglycerides are elevated. They push 200 or so. that's a clear indication that the person is carbohydrate intolerant, meaning they consume more carbohydrates than their body can safely use as energy source. So the excess carbohydrate is converted into this new fat, de novo lipogenesis, that reflects in elevation in triglycerides in the blood. So it's an early sign that you have to, literally you have to cut back on carbohydrates and including the high sources of fructose, whether it's fruits or anything that's made with fructose syrup, which is just about every processed food, and of course sugar and alcohol. I mentioned that last week. So that pay attention to triglycerides even more than you pay to cholesterol, I would say. I
agree 100%. There's such an important window into what's happening. They're a nice real-time test,
yes,
of sort of active metabolism. Some of these tests that we do are more of a reflection over time, but triglycerides give us a nice here and now value. So we like HSCRP. The next on our list here, we like a serum vitamin D level.
For sure.
Wonderful value. We find that in a lot of metabolic syndrome patients or insulin hypersensitivity patients, this is a low value. And whether that's because we're not getting enough natural vitamin D from the sun, we get very little from our diet, or it's just a complete lack of absorption in our gut or conversion of this hormone, we want to keep a close eye on this value. And what's interesting, once it's even without supplementation, I find that when patients are getting a little more active, they're following a low carbohydrate, high fat lifestyle, this number starts coming up naturally. Whether they're getting more active, they're outdoors more, or they're having better absorption of fats, I'm not quite sure. But doctor, what would you say is when you see that? What's your theory as to why we see low D and it starts rising even without supplementation?
I think for once, when people follow the low-fat diet, first of all, they don't get, because again, that vitamin D is a poor dietary source. However, we still can get it from eggs, especially if they come from chickens that are free range, and as well as from the meat that comes with its own fat content if it's grass-fed. So just by eating more fat, we take in more natural food sources of vitamin D, plus the fat helps us absorb it. It's a fat-soluble vitamin. So and overall, we absorb more of all the fat-soluble vitamins when we go on a high-fat diet. Then, like you said, people start to feel better. So perhaps they do get a little bit more outdoors, and maybe they get more sun exposure. And in fact, that is the best way to get vitamin D.
Sure.
The body produces it from the cholesterol we have in our skin when it's exposed to natural sun rays. So it's a good idea to expose yourself to safely, of course, to the sun, so you get good natural dose, because then you don't overdose. And if the levels are low, and you already put it here on the screen, less than 50. Definitely supplementation is recommended. I personally say, if you take a supplement, I personally like the emulsified forms of vitamin D. In that case, you can take it any time of the day. It doesn't have to be taken with a fatty meal, because if you take it by itself and it's not emulsified, it's not ready to be absorbed, you may not absorb enough of it. So there are many companies that make the liquid emulsified form or the MCT form.
Got it.
And MCT, we know they bypass the gallbladder, so they are absorbed directly. No problem with absorption. That's important for people to know when they supplement, to take in this form, and if it's a regular soft gel, to have it with some fat.
Great tip. And this is one of those that because it's fat soluble, the body will store this in our system, and we can become toxic with vitamin D. So this is one of those things we don't want to just take like we would take a Centrum Silver. We want to know where our baseline value is, supplement with hopefully the advice of a physician, because not everybody needs this hormone. I think you accurately described last week. This is a hormone. It has some very important functions in the body, and it needs to be at an adequate value. But we don't need to necessarily just have every single patient on vitamin D without a measured value, and then we want to track that value over time, because there's been many of my patients who we supplement with vitamin D, they adopt low carb, they're feeling great, feeling better, and we actually have to back down or eliminate that as a supplement because
Right, absolutely. Test and retest, especially if you are prescribed the 10,000 units a week within 2 months, 2 to 3 months, retest, because chances are that you are building up and you can go lower. And I personally use the sliding scale that the Institute for Functional Medicine has created. So according to the patient blood level of vitamin D, it's recommended a certain amount of units of vitamin D as a supplement.
Okay, maybe we can post that link. We're gonna, and again, in our comments section, there's gonna be many questions, and we're going to be able to provide a lot more information in our comments. We're just
and people, what people can do, they can always, of course, I have talked about this in the book, although I do not put in the book because of printing rights and all that. I did not put the handout that I have from the Institute for. I have the rights to use it with my clients, but not to put it in reprint and sell. But people can always PM me or email me to give it to them directly.
Okay, wonderful. All right, moving on. The next test we like is just a fasting glucose. Now, glucose is typically in what we call a comprehensive metabolic panel, or a CMP, or a basic metabolic panel called a BMP. Okay, not to be confused with BNP. N as in Nancy. So we like a fasting glucose to really let us know where each of us are in the morning from a glucose perspective. And I really like to, and we'll talk about this in a minute, but I like to calculate something called the insulin resistance score, the HOMA-IR. And this actually lets us know the relationship between our fasting glucose and insulin, because insulin we're going to talk about in a minute. And we calculate this. And this, let me show this really quick. It's basically, there's two different calculations here, but this is using glucose in the form of milligrams per deciliter times insulin divided by 405, and we get this insulin resistance score, which is really a wonderful test. Even gives more information than a fasting glucose or even a fasting insulin. It gives us the relationship between the two, which is so important. But we definitely want to get a fasting glucose. And then we'll talk a little bit more about the insulin resistance score in a second. But I want to follow my list here. Along with the fasting glucose, we should get a hemoglobin A1C, which is our 3-month blood sugar average. It's what percentage of our blood is actually glycated or exposed to the glucose molecules over their lifespan. So each hemoglobin cell has a lifespan of about 3 months, and so we can detect that. And this is generally what we're using. In my old practice, I would use just hemoglobin A1C, and we would use anything less than 5.7 was considered normal. 5.7 to 6.4% is called pre-diabetic, and then more than 6.5% is called diabetic. And we're trying to get a little bit more specific with this because HbA1c, you can be insulin resistant and have a completely normal hemoglobin A1c. You can have a completely elevated hemoglobin A1c and have a low insulin, but that's actually very dangerous, actually. So
it's the end of the spectrum.
Hopefully we're not to that point by the time you see one of us, but so that's why we need to understand the relationship of these values. I like as low as hemoglobin A1c as I can possibly get in patients. Mihaela, how do you feel about it?
Absolutely, because hemoglobin A1C tells us only about the sugar, right? Which the body will always attempt to keep it at safe, normal levels. And how it does that? By producing more and more insulin to get the same result.
Right.
It's like, I like to use this analogy of somebody delivers a truck full of boxes. And all of a sudden, you have to, because they dump so many boxes at you at one time, you have to hire more people to clear the boxes, right? To put them in the storage room. So at one point, you can no longer find people to clear the boxes. And that's the equivalent of diabetes when you have elevated blood sugar. And by that point, like an advanced type 2 diabetes, where there's no more insulin. Like the workers are the insulin and the boxes is the sugar. So until that happens, you may still measure, you may have a normal hemoglobin A1C, maybe even normal fasted blood sugar.
Yeah.
At what expense? So that's why it's important to look at the insulin and to see the ratios, because if you have, let's say, a fasted blood sugar of 80, which is wonderful, but your insulin is 13, fasting insulin is like a big red flag. That means that your body has to produce a huge amount of insulin to keep that blood sugar where you actually see it.
Right.
Versus having a fasted blood sugar of 80 with a fasted insulin of 3, which is like, wow, that's a person that's managing well their blood sugar, responds well to, they eat just enough carbohydrates for their body to metabolize it. Right. And then you can expect this person to have low triglycerides and a good average blood sugar, a good hemoglobin A1C.
Well, yeah, that's a good segue to our insulin. Another important test that many physicians are not ordering. We like it. I think the scale on our lab is 3 to 9. I know you like it low.
Less than 5.
2 to 5 is an ideal range. I would say 6 to 9 is a borderline range, and really anything above 10, there's a problem. The body is taking in way too many carbohydrates and producing way too much insulin, and really anything above 10 is a red flag, big red flag of a problem. And then we'll go back to the HOMA-IR. So this HOMA stands for HOMA, stands for homeostatic model assessment for insulin resistance. That's a big word, and it doesn't mean a lot to us. We just call this the insulin resistance score. And this is, again, a calculation of glucose times insulin divided by 405. And so if we have a score of greater than 4.2, and our scales will differ on this, but this is a general guideline, more than 4.2 is considered high risk. There's a big problem. I see this day in and day out in my practice. We see high levels of insulin resistance, and it's a very important marker. And we want to be less than 2.6. And Mihaela, I think you want to even be lower than that, correct?
Yeah, well, the lower the number, the better. The closer to 1, the better. I have, in my book, I actually give 2 examples with, so people can see the difference between, same fasted blood sugar with different insulin levels, to see how you get those, completely different, insulin resistance scores.
Yes.
On one example, I come up with 0.68 insulin resistance scores versus the 2.77, which is considered not that high. Right. Yet this is for a person that has a blood sugar of 87 with the 13 insulin. Yeah. Versus same 87 with a 3.2 insulin.
And this is important. This is why I think trending labs is also very important, and because we're not always going to have the same risk factors present themselves at the same time. And a lot of disease is situational. We can have a period of stress in our life. There can be a period of time where we're not eating, exercising, sleeping well. And we need to get away from the notion that disease, especially in our arteries, happens over time. We can have a plaque form in a very short period of time, depending on what's happening in our lives. And so we can be living perfectly and just have the most horrendous several months of our life from a stress perspective, diet perspective, lack of exercise, and we can actually form plaque in a small period of time. So I want to, it's why it's so important for us to track these values to see the trends of our lives. And heck, we've had, I'm not suggesting everyone go get these labs done quarterly. I won't discourage that either, because these labs are inexpensive. They can be, the information can be gathered very easily. And if you're tracking with a professional like myself or Dr. Telecan, I love the values. It gives us a nice picture of what's happening in a person's life. So just wanted to offer that bit of information.
And what I recommend my clients to do, to create an Excel file and have all these labs with their date. So over time, they can see the trend. They can look back, whichever many often they check. If it's once a year, 4 times a year, they can see the trend, what goes up, what goes down. And then they can also think, what did I do in my life during this time to see this kind of change? Right. Because then you have more knowledge, and you know what maybe you had, like you said, an intense stress period in your life, or you didn't sleep enough or something. So you know that's a red flag. You've got to pay attention to that thing. Maybe your diet is perfect, right? But you're chronically sleep deprived. So you've got to prioritize that. But if you don't track, it's difficult. You really have to be your own detective. So, and the more data you have when you go to the practitioner that you work with, the better they can help you.
100%, especially, and it really helps us as physicians to have that data, so we can know where a person has been, where they've come, where they're going. So I love the information. I'm one of the physicians that likes it. I know a lot of us physicians are pressed for time. We only have 7 minutes in my old practice. I only had 7 minutes per patient. It's just going to be virtually impossible for a physician in that environment to really be thoughtful with these values, and they're probably going to be overwhelmed. So it's so important to partner with a practitioner that has an understanding or wants to have an understanding of these values and can be a true partner and collaborator moving forward. So I just want to say that. Next, let's talk about ferritin. Kind of a neat test. So this is part of our iron family of testing. Traditionally, it was used to just measure iron absorption in the body. For our purposes, we're using it as a sign of liver inflammation. So we've talked about the traditional liver enzymes called the ALT, AST, and alkaline phosphatase, but a lot of times those aren't elevated, and they don't show us if a person's developing liver inflammation, or fatty liver is another way to describe that. And because we know carbohydrates, fructose in particular, is a driver, sugar is a driver of fatty liver. And ferritin is a nice way of letting us know that's happening. And alcohol is also a driver of fatty liver. So someone can be low carb but drink 3 to 7 drinks per night and have a really high ferritin and think they're still doing well because their liver enzymes are normal, they're maintaining a good weight, but we're actually seeing fatty liver changes in inflammation, which ultimately will drive insulin resistance and ultimately problems moving forward. So I like looking at ferritin. The ideal there is 40 to 70, kind of the similar to the vitamin D level there, but we like this number to be as low as we can get it, if possible. Right,
because again, iron is rusting. It acts as an oxidative agent. So too much iron is not a good thing. Too low is not a good thing. Again, it's that sweet spot that we need to find. And it's one test that, especially for men, it's important because they don't bleed, and for post-menopausal women because they stop bleeding. Right. Once you're still menstruating, maybe you're okay. Yeah. With ferritin levels.
Yeah. So that's a kind of a neat one lately that we've been adding, and high ferritin too is probably a more valuable assessment of cardiovascular risk and prediction than LDL cholesterol, which I think is a very poor predictor of heart disease. So ferritin, let's pay a lot of attention to that. And again, it makes sense to us because we know that, and we feel so strongly about this, that heart disease and most metabolic diseases are caused by insulin resistance. And again, when we find that person that has heart disease, we look back and look at the risk factors that are and identify the ones that we can change once we're given that information. So the next thing let's look at is the CMP. We mentioned this. This also contains glucose. It contains our electrolytes, sodium, potassium, chloride, carbon dioxide, calcium. It contains our liver enzymes, our renal function called the blood urea nitrogen, and creatinine. And I believe that's it. I think that's I think that's all we have there. And we like it for the glucose, we like it for the liver enzymes, the renal function, and I like the electrolytes for that. So it's a very basic test. This test is extremely inexpensive, several dollars depending on where you go. But one of the tests that I really like as well along that liver enzyme line is called the GGT. It's another form of a liver enzyme, but it's not normally included. And this tells us very specifically where inflammation is coming from. This is very specific to the liver, and it's a very early liver inflammatory marker. So when our traditional liver enzymes are normal, if we look at the GGT and it's elevated, again, a very powerful heart disease predictor. If this test is elevated, it's our liver is really in distress, and we need to identify why. Let's see here. I like to look at hormones, and we need to have another hormone talk, but I think especially in men, we can get a lot of information about our testosterone level. If we see a man who has a low testosterone level, we should be immediately thinking metabolic syndrome, insulin resistance, insulin hypersensitivity, and we have to assume that they're on their way to making plaque. And testosterone is a very valuable indicator of metabolic disease. Not in everybody, but we also don't want to be fooled by it either, because there can be high levels of testosterone and a person can still have metabolic disease. But when it's low, we're generally thinking that there's a metabolic issue happening. And Mihaela, I know you agree with that.
Right. Funny, I didn't talk about testosterone in my book, mainly because I work with women mostly.
Right.
So I didn't think to include that. But yes, it's important. I think last week we mentioned how we can raise testosterone. And of course, you have to look and report to the age of the person, right?
Sure.
But a great way to raise testosterone, both in men and women, is high-intensity interval training, along with low-carbohydrate diet. Both of these have this hormonal, anti-aging hormonal effect, where they help us raise testosterone and human growth hormone. And these are valuable hormones that tend to decline with age, and they are important in preserving our youth or youthful looks and muscles and bone density, which are so much more important to pay attention to as we age, because of all the age declining losses. I guess I said it right. As we age, we have more losses in muscle and bone, and
absolutely.
And those hormones are crucial in helping us prevent that.
And then some of the ones we mentioned last week that are also helpful: a homocysteine level, and Mihaela, talk a little bit about homocysteine and why this is important. For those that don't know, this is a marker that when elevated is linked to, gosh, you name it, stroke, heart attack, Alzheimer's disease. So it's a powerful a marker of metabolic disease. But Mihaela, talk a little bit about your utilization of this.
This is actually an amino acid, and it's important to test it. And like you said, when it's elevated, it's a red flag again for all those chronic diseases. And when one person has elevated homocysteine, I would highly recommend testing for the genetic defect, the MTHFR,
yes.
SNP, because and it's very common actually. Many people have it, and in that case, the person will require a supplementation, high-level supplementation with the activated form of folic acid. This is it's a very complicated pathway in the folic acid metabolism and B12, so they can mask each other. They can be associated with anemia. So you don't know, are you folic acid deficient or B12 deficient? But it's important to do this test. And I know there are practitioners that actually even run it routinely on patients. And it's important because once you use this high dose of supplementation of the activated folic acid is 5 MTHFR, I believe it's called.
Right.
And homocysteine lowers, the person detoxifies better, they lose weight better, and then of course we reduce the cardiovascular risk factors as well that are associated with having this elevated homocysteine.
Mihaela, do you think it's I see elevated homocysteine, almost exclusively in metabolic syndrome, and I think it goes back to the vitamin D issue, where we also see low vitamin D. We also see low omega-3 levels in these folks. And you can't help but think, gosh, they are so carb adaptive. Their body is almost only absorbing carbohydrates or glucose just to sustain themselves, and forgoing the nutrients that our foods are providing, including vitamin D, including omegas, and obviously including B12 and folate. Do you see that as well, where once you kind of correct the absorption issues and you become fat adaptive, that the homocysteine can fall?
Normalizes? I did not see that. I guess I don't have enough data to answer that, and I don't know in the literature if this has been.
There's not a lot of talk on it. I mean,
right.
These associations between low vitamin D, metabolic syndrome, low testosterone, metabolic.
Right, but I don't know about the causality. Like if you eliminate the carbs, if that helps you raise vitamin D and lower homocysteine, that I don't know. But I do know that a high percentage of the population actually has this MTHFR defect.
Yeah, I do.
And, they do require high. You have it?
Yeah. I have a variant, yeah.
A variant. I never even tested, but my homocysteine is always good. So I have no reason to suspect that I would have it.
Mine was high. Mine was, I believe, 17, and I supplemented with methylated folate and methylated vitamin B12 called methylcobalamin. And my next check, it was down to 6. So my body was absolutely telling me that, yes, have to supplement. And then let's talk about omega-3, a very important value. We have omega-3 testing now, and there's even what's called the omega-3 index, which gives us a ratio of our total omega-3 level to our total omega-6 level. And we can get these numbers now to see how much balance we have in our body with omegas. So do you want to talk a little bit about omegas for us?
Right. So these are both omega-3 and omega-6 are our essential fats, meaning our body cannot produce them from other fats we acquire from the diet, so we have to get them through the diet. Omega-3, the most absorbable form is the marine source, the one that we get from fish. And when we say that, we refer to the components DHA, EPA, and that's what we find in the cell membranes. We do get plant source, the long omega-3 chain from flaxseed and hemp seed and chia seed. However, the body has to convert it into DHA, EPA, and the conversion is not necessarily good in most people. So, and on the other side, the omega-6 is abundant in our diet. And in fact, when I log even my food, and I think I'm eating clean and all that, and I look at the ratios of omega-3 to omega-6, I always get, just from nuts and seeds, I'm not using any vegetable oils, I get at least 16 times more omega-6 than omega-3 in my whole foods-based diet. So it's highly recommended for people to supplement with omega-3. I've never done for me personally an omega-3 index, but it's a good test to do to see what's the ratio, what do you have in the cell membranes. What's the ratio between this inflammatory and anti-inflammatory fats? Because the omega-3s are the anti-inflammatory, the blood thinning ones, those that prevent the aggregation of red blood cells, right? Those that relax the blood vessels. That's the good fat, the omega-3 that you want more of to prevent cardiometabolic syndrome.
Right.
Versus omega-6, they do the opposite. Right. They would cause more inflammation, hardening of the arteries, clogging of the red blood cells. And it's not difficult to get too much omega-6 without even taking
very easy
canola oil and soybean oil and any other vegetable oils.
Right.
So it's, even if you don't test for it, supplement with omega-3. Eat sardines 2 to 3 times a week. Probably that's the safest fish that's high in omega-3s, that's not polluted and overfished and all that. Sardines, anchovy, mackerel, all those small fish that live in cold water. And supplement, I would say easy at 3 grams a day. It's pretty safe for everybody, 3 grams total. The best is if you buy a fish oil supplement to look at one that has the DHA EPA breakdown. Okay. So you know exactly how many milligrams of each one of those fats that actually end up in your brain and in your every cell of your body, basically.
And the total of the DHA EPA is should equal about 3,000 milligrams, correct?
Yeah, it has some other fats in there because there are very few oils out there that are pure. Sure. Just omega-3. So maybe out of the 3 grams, if you get a 70% DHA EPA, it's good.
Okay.
I don't have I can't remember the numbers, my bottle in front of me to see what that has. Or krill oil.
Yes.
Krill oil or fish oil. I alternate between the two. And I think in your office, people can get you carry from Proterra, right?
We do carry the Proterra.
Orthomoleculars has a good one.
Absolutely.
I like theirs. And Proterra has the krill from Complementary, because now there are like 3 companies in one.
Correct, yeah.
That's what I use. I use the krill from through Proterra, and if I get the fish oil, I get from Orthomoleculars.
Okay.
I like their 820.
And for those that want recommendation on supplement lines, there's so many good products out there, but there's also some bad products out there as well. So we can help guide folks there as well.
I always tell people to try to find a practitioner they can get it through. And even through us, if anybody's interested, they can PM me and I can give them my professional code and they can purchase. And I'm sure if they go to your office, you probably have a mini store.
We have a few. We try to provide it for guidance for our patients' convenience too.
Yeah.
But we try to just educate and then provide guidelines. We try not to. We're not the vitamin shop for instance.
No. But like maybe few staple.
Absolutely. Well, this is great. I'm going to post on the comment section just sort of a breakdown of all of the labs that we mentioned here today. And I think from how often should someone get these done? That really depends on what's happening. If someone has some really pristine looking values, I think once a year is adequate. If we are in the danger zone from a metabolic perspective, and there's a lot of, I would say, high risk readings, I would not be satisfied with once yearly. I would really want to keep a close eye on these values and monitor for correction and reversal of these abnormal values. So I will check them as often as
3 months.
Yeah, 3 months there, on a quarterly basis, I think is not outside the realm of reason. So that's what I like. But again, I love labs. I love looking at them. And I just love the reversal of these numbers. It's just so powerful, I think. So that's the advantage that having the office and having the ability to draw the blood here in the office, we have a lot of advantages in that sense. So.
Yes. Well, for our listeners, they can always come and listen to this video again because there's a lot of information. They can take notes. And my book is coming up soon, and I cover just about all of this, I think, except for testosterone. I cover all the books, all the labs. I have a little table with them at the glance, optimal values and all that. So that's the power in having a book. You can always use it as a reference or resource so you don't have to memorize things or look for scrape paper. Where did I put that information? Right.
Please comment. And again, just to echo Mihaela's book, Make Peace with Fat. I'm loving it. It is a book that's extraordinarily well written, and I'm not just saying that. I'm kind of a grammar police and composition police. So I'm really enjoying it, and it's a wonderful book for practitioners such as myself, who are highly interested in these concepts and utilizing them with our patients and ourselves. So I think it's just a wonderful, easy to read book. So I'm looking forward to it making its official debut. So thank you for that.
Thank you. Thank you.
All right. Well, again, any questions, please let us know, and we'll be back not next week, but I believe the week after that.
The week after. I'm going to tell you the date right now. It's not going to be the 15th. It's going to be the 22nd.
Okay.
Okay. Is that the week of Thanksgiving?
It is. So maybe we talk about how to navigate the holidays.
That would be cool. To give some suggestions for some low carb items on the Thanksgiving table that low carb, high fat that you can enjoy. Take them to your dinner or prepare them.
Absolutely. That'll be really terrific. Well, until then, I look forward to our next talk. And again, this has been so great. I'm glad we did it again because it's just really important information. So hope everyone enjoys.
Thank you. Yes. Have a good one. Bye.